Interim Program Director for Dining for Women. With us, we have Laura Haight, our Communications Director. Hi, Laura.
Hi, everybody.
And we also have with us Jessie Cronin from Gardens for Health International. Jessie is joining us from a tiny little location outside of Kigali in Rwanda. Gardens for Health International, or GHI as it is known, was started in 2008. The Dining for Women grant that they will be receiving is for $43,867, and they will be targeting about 120 mothers and 600 children on the program. So, Jessie, why don't you go ahead and tell us more about your program?
Wonderful. Thank you all. I'm incredibly excited about this opportunity. And I know that we have limited time, so I'll jump right in to tell you a little bit about Gardens for Health. All right, I hope that you can all see the presentation that is up on the screen. But at Gardens for Health International, our mission is to provide lasting agricultural solutions to chronic childhood malnutrition. So what you see in Rwanda, where we work, and around the world, is that most of the children who are going hungry come from families who are farming. In Rwanda, 44% of children under the age of 5 are chronically malnourished, yet 85% of families are farmers. And yet the most common treatment for malnutrition is emergency food aid, these high-calorie packets of sugary peanut butter paste fortified with a lot of vitamins and nutrients that help kids gain weight in the short term but don't address the long-term challenges that led to the problem in the first place, which is where we step in. So Gardens for Health was designed to bridge that gap and to help provide vulnerable families, and especially to work with mothers, to give them the tools to overcome malnutrition for the long term. And we do that in 2 ways. The first is we provide comprehensive health education. We cover what good nutrition is, what good shopping practices are, cooking behaviors. We talk about breastfeeding, complementary feeding, and then a lot of the related causes to malnutrition. And all of our trainings are delivered by peer leaders who come from the communities they serve and who've experienced many of the same challenges as mothers in our program. And our materials, one of which is on the screen right now, our color wheel, are all designed to be really relevant and useful for audiences that can have low literacy levels. And so, for example, this is how we teach nutrition. It's not, we don't talk about carbohydrates and proteins. We really focus on having 4 colors on your plate at every meal. And in a country like Rwanda, where the families we work with aren't eating processed food, that really gets you to a balanced diet. So health education is one big piece of the puzzle. The other missing piece of the puzzle for the families that we serve is a home garden. So most of the families we work with are farmers, but most are farming commodity crops. So they're growing things like maize or coffee or tea that they're selling to market. And as we have all, I'm sure, learned over time, income doesn't get distributed the same way that household food does. Men tend to control income. They take the coffee beans to the washing station and come home with the money. So less of it goes to the family and to food. And so what we do is we work with every family in our program to design a garden around their home that will promote family dietary diversity. So they're getting the mix of nutrients they need, and also crop biodiversity, so that you're building the health of the soil over time. And we realize that, you know, people are people all around the world. Everybody wants to have a choice in what they're doing. And so instead of having a set seed package that we just hand out to everybody, we talk with mothers, and we have 9 different categories, and families choose different types of market vegetables, for example, or different types of legumes, different types of leafy greens. They choose between chickens or rabbits, and we help them design a garden. And so that's kind of the 2 sides of our program. Families work with us intensively for 1 season, and then we continue to provide follow-up home visits and seeds for 2 more seasons. So we work with families for a total of a year. And what we're seeing is that it's working. Kids are getting and staying healthy. In one cohort we just looked at, 71% of children were at a healthy weight a year later. We're also seeing that families are eating a more balanced and nutritious diet. We use this thing called the Household Dietary Diversity Score, which basically measures how many different types of food families eat in a given day. And 68% of families report that they're consuming a high dietary diversity diet after one season. And then the last thing and the most exciting thing we see is that families are eager to engage in our program. They're really excited about the work we do. And we see this in attendance rates. Families walk up to an hour, sometimes more, to attend our trainings, and we still have 86% attendance rates at health trainings and 83% attendance rates at agriculture trainings, which is even more impressive because agriculture trainings take place outside, and Rwanda has 2 rainy seasons. So the numbers are exciting, but I think what really tells the story of our work is the story of individual families and individual mothers. One of those mothers is a woman named Benanti, and she enrolled in our program last January when her 2-year-old was diagnosed with malnutrition. And when she talks about what happened, she was confused. She thought she had enough food for her son. She was feeding him potatoes, and he wasn't gaining weight. And it was because he wasn't getting a mix of vitamins and nutrients. 2 seasons later, you can see there's a picture of Benanti is standing in a thriving garden. Her son is at a healthy weight. And most importantly, Benanti has found a community of women who she now feels that she can turn to for support, which is helping not only to build the health of her child, but also to help her feel empowered as the caregiver. And she's looking forward to someday being around to have healthy grandchildren. So what Dining for Women is letting us do is to fund our program at Bumbogo Health Center in Gabo District. We'll work directly with 120 families like Benanti's, 120 mothers, and about 600 children, and we'll give them that lasting roadmap out of malnutrition. And we're really excited and really grateful to you guys for giving us this opportunity. So thank you. And with that, I'll turn it over to questions.
Okay. Thank you, Jessie. Thank you for that wonderful presentation. I'm waiting for you to come back on the screen at some point. My first question, Jessie, is the initial clinical diagnosis of malnutrition is done at your health center?
Yes. So the way that our program works is we work in partnership with the health centers, and we collaborate with health center nurses and nutritionists and with community health workers to help them do growth monitoring campaigns. One of the challenges we see in a lot of communities is that there's a lot of stigma around malnutrition and a lot of misinformation. And so often children don't come into the health center presenting with malnutrition until they're coming in with something else that's really serious. Malnutrition is a contributing factor in 2/3 of all early childhood deaths in the developing world, and so often kids are coming in with malaria, with TB, with serious diarrheal diseases, and malnutrition is an underlying cause. So we work with health centers and with community health workers to conduct growth monitoring campaigns in the advance of every season, and then we enroll 40 families, and all of them have at least one child under 5 who has a clinical diagnosis of malnutrition.
Okay. So since you work so closely with the other health centers, scaling up the projects should not be a problem in the future, correct?
Yes, that's been the really exciting part of our work. Not only is our health centers, we really like health centers as an entry point for a lot of reasons. We really believe in building on existing systems. We don't want to come in and create some parallel health system that people become dependent on. We'd much rather work in partnership with public health systems, and this is a way for us to do that. But it's also, you know, we've been expanding. We're now covering 1 district in the north, but there are hundreds of health centers in Rwanda, and so there are hundreds of entry points, and there are thousands, if not more, health centers throughout sub-Saharan Africa. And so it's a place that we feel like it's a model that can really work in a lot of contexts.
Okay. Could you address some of the issues that contribute to childhood malnutrition? For instance, diarrhea is a serious thing, immunizations, the water and the sanitation. And could you also please address that part of your program involves getting livestock for the family? But there's also issues about having livestock close to children kind of increases the infection rates. So could you get into some of those variables that contribute to malnutrition?
Sure. And I think that's a really important point you raised. I think malnutrition is a really complex challenge. In a lot of ways, it presents a health problem, but what it really is it's an issue of poverty and an issue of lack of access to both the food and the medical treatment that kids need. And so when we went to design our program, we actually talked to mothers in the community where we worked, and we wanted to understand what, beyond not just having enough food or not knowing what to cook, what else was making it hard to feed their kids. And so a lot of the kind of medical causes were the first ones that we developed trainings to address. And so hygiene is one of the first things we teach about. And we actually provide a year's worth of Siro, which is a water purification kind of droplets that you put into your water. We provide a year's worth of Siro to every family in our program. We teach a lot about hygiene. We teach about common illnesses, malaria and TB. And then we focus a lot on pregnancy, breastfeeding, and complementary feeding. Because what we really see is it's that moment when kids stop breastfeeding and start eating solid food that they're most at risk. And so we've actually developed some complementary feeding recipes for mothers in our program to use, so that instead of handing your 2-year-old a potato to gnaw on, which they will gnaw on, and you will think that they're getting a lot of food and they're not actually getting a lot of nutrients, we help families learn how to prepare really nutrient-dense foods that involve basically mashing together proteins and carbohydrates along with vegetables. And so those are things that we focus on. And then we also realize there's a lot of family factors that make it harder for mothers to feed their kids. So we teach about savings. We talk about gender-based violence. We talk about mental health, because maternal depression is incredibly linked to malnutrition. It can be a really vicious cycle. It can be a really stigmatizing thing, and it can be a really isolating challenge for mothers. So our health training tries to kind of address as much of that as we can. And then by partnering with health centers for things like vaccines, we're able to actually leverage that relationship so that the health center can be the healthcare provider. Because we are not a healthcare provider, but we teach about HIV/AIDS, and on that day, the health center is on hand to give HIV tests. We teach about family planning, and they're on hand to provide the family planning. And so that's one of the real strengths of working with the health center. And then in terms of livestock, it is true. There are risks of having livestock close to children. Almost all of the children that we work with are already in very close proximity to livestock. And so what we really feel is that having access to a consistent source of protein and a consistent source of income. Because livestock is both a source of protein, but also families choose. If they choose rabbits, rabbits multiply really quickly and sell really well at market. And that can be a really great source of income for a mother. Chickens tend to be more a source of protein. Sometimes they'll sell some eggs, but it's great to be able to have your kids eat eggs and then multiply the chickens.
Yeah. So, I mean, working in this area, it's kind of a family intervention, correct? Can you comment about the growth monitoring? Do the mothers kind of either take the children to be weighed often enough so that they can tell when they are beginning to kind of, move over the growth charts?
So we actually do that as a big part of our program. So at every health center where we work, including Bumbogo, we have 2 field educators who deliver our program, and they're talented community leaders who we have hired really based on people who've overcome similar challenges. And then we have 2 monitoring and evaluation agents who are also talented community leaders who are in charge of growth monitoring for all of the kids in our program. They assist with the big growth monitoring campaigns that we help support at the start of each season, but then once kids are enrolled in our program, we weigh and measure them on a monthly basis, and we actually have a system set up so that if a child does drop in weight at any of those monthly weigh-ins, our field supervisors get a report, goes straight to the field educators, and we do a home visit immediately. because we do realize, especially in that first season, how vulnerable kids are. We continue growth monitoring on a seasonal basis for the first year, and then we follow up on an annual basis for the next 36 months. So we were really trying to track the long-term impact of our program on these kids, and also to make sure that kids don't fall through the cracks. A big part of what we do is case management and advocacy for families in our program.
Could you comment a little bit about two things? Typically in rural communities, they breastfeed for longer periods of time, but often you cannot breastfeed too long exclusively. You need to do the introduction of healthy foods. So what is the cultural norms in the area you're working in, and how is that all playing out?
So where we work, the cultural norms tend to be, families tend to have children in pretty rapid succession. They tend to breastfeed a child until they're 2 and then immediately get pregnant again. We encourage longer breastfeeding, but we really focus on what are good breastfeeding practices. We focus a lot on maternal nutrition, both prenatal and then while breastfeeding, because what the mother is eating is incredibly important, and then we focus on this complementary feeding. It varies a little bit from kind of community to community that we work in, but we tend to see people breastfeeding for about 2 years.
Okay. I think we only have time for one more question, but could you comment a little bit on the under 5 mortality rates, and what is kind of birth weight issues that you see in newborns in the area you're working in?
So this is really interesting, and a lot of new data is coming out, and what they're finding in Rwanda is that an increasing number of children are actually being born already underweight, so they're starting out at deficit, they're starting out stunted, and there's a ton of research around the importance of the first 1,000 days as a real window of opportunity, and so our program targets any child under 5, but we really focus on kids under 2 because that's where we feel like we can have the biggest impact, because that's where there's the real opportunity. And we focus a lot on maternal nutrition because while we do teach family planning, odds are most of the mothers in our program are going to go on and have 4 children. And so one of the things that we really believe in is that prevention is key. And malnutrition in a country like Rwanda, which is producing enough kilocalories per person to feed the country. It's incredibly fertile, especially in the area where we work. 91% of people are farming. Malnutrition is a problem that we can solve. It's a question of food systems, and it's a question of really empowering mothers with the knowledge and the access to make the decisions for their families.
Yes. Lastly, Jessie, Rwanda has been through so much, and it's so heartening to see how the people are turning around and the indicators are turning around. Can you lastly comment on all of that?
Absolutely. I have to say, and I've worked in other parts of Africa. I've worked in Tanzania, and I've worked in Swaziland, and Rwanda is a country. I've been with Gardens for Health for a little over 2 years, and this is my 10th trip to Rwanda. And every single time I come, it feels like there's forward momentum. And malnutrition has been a persistent challenge. It's been a little bit of an unintended consequence of some agricultural policies that really promoted monocropping as a way to increase GDP, which is a really good goal for a country to have. But what it led to is people stopped growing food at the home for homestead food consumption. We work closely with the government to change policies around that, and then we work at the household level. And what we've seen is the government's incredibly innovative. They're incredibly receptive to and supportive of the work that we do because malnutrition is a national priority. They came out with a cost of hunger study about a year ago that said malnutrition was costing Rwanda 11.8% of its GDP. And Rwanda is a country on the move, and so I feel like that report, more than anything else, skyrocketed malnutrition to the top of the priority list.
Jessie, thank you so much for participating in this Google Hangout with us. It was wonderful talking to you and learning about your program. We at Dining for Women wish you a lot of good luck. Thank you so much. Thank you, everybody, for joining us at this Hangout. We will see you next time.
Thank you. And before I lose you, if I could just offer one invitation. Our headquarters in Rwanda is on a 5-acre farm. It's only 15 minutes from the airport because we believe in living and working in the context that we are teaching to families. It's spectacularly beautiful, and every day we feed about 100 people from our staff in the community at one big long table in the middle of our fields. We've been told we have among the best lunch in Kigali, so if you ever find yourselves in Rwanda, we would love to have you visit us. And with that, thank you.
Thank you.